Assalamu alaikum. Urethral stricture. Urethral stricture is the narrowing of the urethral meatus and the urethra. Causes of the etiology may be inflammatory, traumatic, iatrogenic, and idiopathic. Inflammatory includes secondary to urethritis or secondary to balanitis. Traumatic includes bulbar urethral injury, pelvic fracture urethral disruption injury, and iatrogenic means secondary to urethral instrumentation, secondary to urethral catheterization, secondary to transurethral prostatectomy, and secondary to radical prostatectomy. Iatrogenic is actually caused by the doctors or the physicians, and idiopathic pathophysiology. Post-inflammatory strictures are less common since the introduction of effective antibiotics. The most common cause was gonorrhea, and nowadays antibiotics are there to treat the gonorrhea very effectively. The stricture is most commonly seen in bulbar urethra. There is infection in the periurethral glands causing periurethritis, which leads to fibrosis. Most stricture appear within 1 year of infection. Balanitis xerotica is a rare condition characterized by fibrosis. Cause is unknown. Stricture is long and difficult to treat. Post-instrumentation stricture follow endoscopy or catheterization and affect any part of the urethra. Post-traumatic stricture are also common. Bladder neck obstruction can occur following transurethral resection of the prostate for carcinoma of the prostate. Clinical features. They include symptoms like hesitancy of micturition, straining to avoid the urine, and poor urinary stream. Patient is mostly young, in their 20s. As the stream becomes narrow, micturition is prolonged and followed by post-micturition dribbling. Because the urine stays within the bladder and takes long to empty the bladder, and at the end there is dribbling also. There is urinary frequency, incomplete bladder emptying, detrusor overactivity, and urinary infection. The well-established stricture may be palpated as scarring along the line of the urethra as a scar. The patient may go into urinary retention. Urethroscopy allows the stricture to be viewed as a circumferential scar. When we see through the urethroscope, we see that the stricture is not in a straight line, but it is rather circumferential. Urethrography uses water-soluble contrast medium show extent of the severity of the stricture. Complications: UTI, which responds to antibiotics; recurrence of the UTI because of residual urine in the bladder; bladder outflow obstruction; bladder calculi because this solute stays within the bladder causing the calculus formation; renal impairment because of ascending UTI; retention of urine; periurethral abscess; urethral diverticulum; and false passages in the urethra because of the attempts to pass the Foley's catheter. Treatment of UTI. Urethral dilatation superseded by endoscopic incision, internal urethrotomy, or by formal reconstruction of the urethra, urethroplasty. Reconstruction is urethroplasty, and dilatation is internal urethrotomy, that is breakage of the obstruction. Urethral dilatation has place in old men with short stricture treatment. Internal myotomy cures 50% of the short strictures and strictures in bulbar urethra. Recurrent stricture require urethroplasty. If not willing for urethroplasty, then the patient treated by intermittent self-dilatation with soft hydrophilic catheter or on a regular basis for lifelong. Short traumatic stricture should be treated by urethroplasty with 90% success rate. Thank you. And the reference is Short Practice of Surgery by Bailey and Love, 26th edition. Thank you.